Irritable Bowel Syndrome, or IBS, is a chronic, relapsing and often debilitating disorder of the gut-brain interaction. Typical clinical features are abdominal pain, which is associated with a change in stool form and/or frequency. It may be related to defecation and it's often associated with bloating. IBS may be classified by the predominant stool type, including diarrhea predominant, mixed, unclassified or constipation predominant. There's around a 15% prevalence of IBS in the UK, and commonly the onset is after 40 years old and affects females more than males. IBS is a diagnosis of exclusion. This means that we need to suspect the condition, but we need to exclude other causes of symptoms, such as ulcerative colitis, Crohn's disease, celiac disease, and gastritis, before we can reach the diagnosis. Symptoms are typically chronic and often exacerbated by stress, menstruation, or post-infection. Examination is often normal, but abdominal tenderness is common. Consider endoscopy if you're unsure about the diagnosis. In managing IBS, we need to first of all make the diagnosis. Typically, this would involve a classic history, as well as abnormal tests. If there's any diagnostic uncertainty or changing symptoms in known IBS, these patients need to be referred on. It's also important to consider checking a serum CA125 to exclude ovarian cancer, as the symptoms can often be very similar. Treatment is focused on symptom control, starting with lifestyle and dietary measures. For those patients with constipation, we need to ensure water and fibre intake is high, and we need to try laxatives. Those with diarrhea as the predominant feature, we need to identify trigger foods, reduce fibre, or consider bulking agents or loperamide. In bloating, we need to consider the use of antispasmodics, probiotics, or what would we call a low FODMAP diet. Patients often benefit from some cognitive therapy, hypnosis, and low-dose amitriptyline, especially if there's associated psychological symptoms.